Our next presentation is by Dr. Blair from Carolinas Medical Center, identifying risk factors for postoperative sepsis in laparoscopic gastric bypass.
Good afternoon. I'm going to take us back to NSQIP land, where there's much to learn, but some limitations. We have no disclosures pertinent to this talk. Obesity, as we've heard previously, is a significant burden in this country today, with up to 69% of the population being reportedly overweight. It's a leading cause of premature death, and we all know that bariatric surgery is an effective method for treating obesity, though it does have complications, as you can see here, including the risk of postoperative sepsis and mortality related to that. The purpose of our study, we wanted to look specifically at laparoscopic gastric bypass and in order to identify potential modifiable preoperative risk factors for sepsis development in these patients. The methods we used were we queried the NSQIP database from 2005 to 2013, which was the time period during which the laparoscopic gastric bypass code was available. Basically, patients who developed postoperative sepsis were compared to those who did not, and we performed standard statistical analysis, including multivariate logistic regression. You can see here some of our univariate results. The overall incidence for the population was 0.82%. You can see that, interestingly, BMI was not different between the two groups. The age was statistically significantly different, as was the incidence of diabetes in the two groups, hypertension requiring medication. Smokers were statistically significantly elevated in the sepsis population. This population had an increased number of PAC years and also an elevated CCI score in the sepsis group. This is a graph representing the rates of postoperative sepsis for the laparoscopic gastric bypass population over time, going down from 1.36% in 2006 all the way to 0.68% in 2013. And this trend was statistically significant. Gender remained basically the same throughout the study period. There was a slight increase in the number of diabetics undergoing laparoscopic gastric bypass over the time period. This difference was statistically significantly different. The amount of patients who had hypertension undergoing bypass, laparoscopic gastric bypass, was basically equivalent. And then the number of smokers undergoing bypass slightly decreased over the time period, as did the PAC years. Age increased slightly over the time, and the CCI score, as a representation of the comorbidities of the patients, did increase slightly over time. These are our operative characteristics for the entire group, comparing the sepsis to no sepsis groups. The operative time was significantly increased in the sepsis group, as was length of stay, as you would expect, as well as 30-day mortality was significantly increased in the sepsis group. Also, complications, as you would expect, were highly elevated in the sepsis group, including a 60% return to the OR for the sepsis group. On multivariate analysis, we controlled for age, race, gender, BMI, and CCI score. You can see here that smokers had a 1.625 elevated risk of developing sepsis following laparoscopic gastric bypass, as did medication-dependent hypertensives, diabetics, patients who had increased PAC years of smoking history, as well as patients who had increased operative time. So smokers have a 63% greater risk of developing sepsis, and sepsis in this cohort was associated with a 38-fold increase in 30-day mortality. So in conclusion, the increased risk of sepsis on multivariate analysis was associated with diabetes, hypertension, smoking, increased PAC years, as well as OR time. So we would recommend smoking cessation and tight glucose control for patients. Thank you very much. I'll take any questions that you have.
Hi, Samer Matar, Oregon. So obviously I agree with your conclusions. However, I don't know if your data can allow us to reach those conclusions. For example, diabetes. You mentioned that we have to tightly control diabetes, but you didn't show us that those patients whose diabetes was not controlled actually had a higher incidence of sepsis. So one recommendation or suggestion I have is, can you go back and look at your, say, A1C levels in these patients and see if that was a factor? The other is, for the purpose of the study, how did you define sepsis?
In terms of the A1C, unfortunately, NSQIP does not record A1C, so I know that would definitely make this study much better. And in terms of, I'm sorry, your second question was?
What was
Definition
your
of
definition of
sepsis.
sepsis?
Oh, the definition of sepsis. I actually have a slide on that. It's very complicated. I looked at this in depth because my concern was, are these sepsis patients, basically, am I looking at patients who are developing leaks, post-operative leak? Is that what I'm showing here? And unfortunately, the definition is basically SIRS plus a positive blood culture. So I cannot specifically say that that's what's being represented here. Unfortunately, it's not that specific. And also, we wanted to look and see whether or not this could be better captured. There are actually ICD-9 codes tagged when patients are readmitted. However, they're not tagged when they're undergo reoperation. So I think that's one thing that could potentially improve this to allow us to say, why are these patients undergoing reoperation?
Dr. Rahman?
Uh-oh, my fellow NSQIP presenter.
I just had a quick question. Given the findings on smoking and the complications associated in patients with smoking, I think we can probably all agree that we all counsel our patients to some extent to really stop smoking before surgery. And I just kind of wanted to throw out an open question to yourself and some of the other panelists. How common is it for surgeons to do nicotine testing prior to surgery and to actually cancel elective surgeries for a bypass in patients who smoke? Just wanted to get an idea of what's happening out there.
Sure. I mean, in terms of how applicable this is, I know that certain insurance companies are no longer obviously covering bypass for smokers. And so I guess in terms of testing patients preoperatively, in our practice it's variable. So not everyone is doing that. It's not mandatory. I don't know if you guys could comment.
Yeah, actually, I was kind of surprised at the high number of patients who were smoking in this review. I mean, 16% versus 11%. I mean, I think, to my knowledge, in most practices, people are fairly strict about it. Just wanted to poll the audience. How many people actually test nicotine levels prior to surgery? So only about half the audience. I mean, because obviously if people admit to smoking, that's the only way it could get entered in the database. So how many people will actually operate on somebody if they admit to smoking at the time of surgery? Interesting. So a few people will go ahead. Do you have those? How many of you who actually will operate on the people who are smoking have your patient sign some type of a smoking contract or something with regards to increased complication rates with smoking? Okay, so let me ask one more question then. How many people in the audience think that smoking causes more complications after bariatric surgery? So everybody does. Okay, so interesting.
My biggest concern about the smoking data is the NSQIP definition being so broad.
Right, it's 1 year. They
it picks
smoked
up everybody
within 1 year.
So presumably some number of those patients were counseled stop smoking but still got tagged as being a smoker when that may or may not have brought their risk level back down to something comparable to a non-smoker.
Yeah, unfortunately, I think that's one of the major limitations is how they define smoking.
Yeah, and one of the audience members also pointed out that the NSQIP is not very clear at differentiating cause of sepsis. So if a person came back in with appendicitis, that would still be called sepsis. So it's one of the limitations of administrative data. Okay, thank you.
Thank you.